This was a case that I presented at a Grand Rounds forum a few years ago. I showed you a photo from this talk earlier, so we'll see if anybody can pick up on that. But this was basically a 48-year-old gentleman who came in complaining of left eye pain. He described this pain as being sort of intermittent in nature. It was more of like a pressure sensation, maybe an aching kind of around his left eye. He had a little bit of occasional foreign body sensation. It was worse when he was lifting weights. He was, sort of a little bit of a disorganized guy, but he said whenever he was kind of picking something up or doing something heavy or bending over, this sensation really got a lot worse. He said it was better when he was kind of sitting up or reading or doing something at his desk, and it had been kind of gradually worsening over several years. He did have a past history of schizophrenia. He had hypertension, which was untreated at the time that we saw him, and he also had asthma, which was also untreated, probably related, both of those to his schizophrenia. However, he had no ocular surgical history, no other past surgical history. His only medication was olanzapine for his schizophrenia. He denied objectively or subjectively any history of alcohol, tobacco, or drug use, and really had no other systemic symptoms other than related to his asthma and schizophrenia. So on exam, this is a classic oculoplastics examination, but he was sort of 20/20 in both eyes. He had no afferent pupillary defect. His ocular motility was full, and his visual fields were full to confrontation. And this is the part I guess I was alluding to as being sort of an oculoplastics exam. But his anterior, his slit lamp exam was normal. His cornea was clear. His conjunctiva was white and quiet. All the usual stuff. His posterior segment exam was unremarkable. So this is, when we get to kind of the oculoplastic section, this is, I would have my residents describe this as a color frontal photograph. Typically you'd then follow up with our eyes are drawn to so-and-so, but here we really can't see much for him at all. But you can see when we had him sort of bend over and strain in the clinic with the Valsalva maneuver, we did see there was a little bit of fullness. Our eye is drawn sort of the supranasal quadrant in the region of, sort of the subbrow region. There was a lot of fullness to that area. So I guess at this point, I would just turn to you guys and ask, what would you guys like to do as sort of a next step for this patient who came into your office? MRI, very good. So would anyone get a CT scan? No. Anything special you guys would comment in the MRI if you were, collaborating closely with your radiologist like we talked about? Anything you'd want to communicate to them or anything you'd want to ask for in the MRI, or would you just say MRI? Yes, so definitely an MRI of the orbits with fat suppression would be important. What else would be important to communicate to your radiologist or ask for from your radiologist? Angiography? Would you do MRI or MRA? MRA or MRV? Angiography or VNOC? I'm hearing votes for both, so we'll do both. And then I heard something in the back from one of you guys in the corner, I think. Anything you would do with the MRI related to that? I thought I heard the answer. Valsalva. So you can do it in the prone. It's hard to have a patient because you guys, I'm sure you've seen an MRI, they can take 30 minutes, 45 minutes. So he would pass out probably if you had him Valsalva for that whole time. But you can have him in the prone position or face down in the machine to help improve, because this was sort of a distensible lesion that increased with Valsalva. So having him face down will put his face in a dependent position so that the blood is going to kind of accumulate in that area a little bit better. So that's what we did. We got an MRI of the orbits with and without contrast and some angiographic imaging that I'll show. Here you can see this is a T1, This is a T1 MR on the left and a T2 on the right. You can see this sort of fluidic, this is contrast sort of enhancement in this region, but sort of a fluidic appearing lesion in the supranasal quadrant. This was done in the prone position, but sort of inverted. And this was the image I showed in the earlier talk that sort of shows this fluid level. You can see there's sort of a level of contrast and then maybe some fat, sort of deeper to it, but basically two forms of fluid kind of within that same lesion. You can see it on the sagittal image here in the supranasal quadrant. And then the MRA that somebody asked for does not really show any connection. So this is, sort of the internal carotid arteries here, some of the branches there. This is our lesion up here. So you don't really see any direct connection between the arterial system and that lesion. So kind of with all that information, putting it together at this point, we have a distensible, supranasal enhancing extracorneal lesion without direct arterial communication. So we know that contrast is getting into that lesion. We know it's distensible. We know it has no communication with the arterial system. So kind of summarizing all that, does anyone have any thoughts on the differential here? Any other thoughts on the differential? Lymphangioma? Okay. Those would be my top two. Anybody else have anything else after I've told you those are my top two? So those are the main ones for us. So I would say green, yellow, red, this is the most likely by far diagnosis. It's a distensible lesion. It clearly has a venous connection, but no arterial connection, and just sort of that classic radiographic appearance of a distensible venous malformation. It could be combined veno-lymphatic malformation. So remember, the lymphatic malformations really have no flow within them because they're just sort of lymphatic. You know, eventually, maybe if you came back over a couple days, maybe you'd see some contrast in it if it was a purely lymphatic lesion, but it could be a combined veno-lymphatic lesion. We wouldn't really know based on the imaging. So those are both reasonable. Lymphatic lesions, lymphatic malformations tend not to be distensible in the same way, though. So that's kind of one thing that knocks it down a little bit. Probably not a or it could be veno-lymphatic malformation, but again, has flow, so probably not a purely lymphatic malformation. That's actually a typo. I did this when I was a resident. It could be an arteriovenous malformation, but probably not because there's no connection with the arterial system, and it's probably not a cavernous hemangioma or cavernous venous malformation because it is distensible. So now we've sort of diagnosed it radiographically. Would you guys leave this alone? What would you do? He's sort of uncomfortable. He has a lot of pain. It's sort of limiting him in life from doing a lot of his activities of daily living. Anything you guys would recommend for him or offer? There's not a right or wrong answer here necessarily. I think you could go either way.
This is the one that you infiltrated with the...
That's very good. I'm glad someone was paying attention. That's good. Any others? So would anyone watch this and leave it alone? Yeah. I think both are totally reasonable options. I think we talked about you never want to biopsy distensible venous malformation because they're very friable and they can bleed and get you in a bad hemorrhaging situation. We did elect to treat this patient because he was having, sort of a lot of symptomatic, involvement of his activities of daily living. He wasn't able to do the things he wanted to do. So we did elect to treat this, but it would be very reasonable, I think, to watch it. It was also, again, sort of in a dangerous area, so there was some thought that if things continued to increase in size, it may be difficult to treat in the future. So this was the one that we took in conjunction with neurointerventional radiology. This is not something that I would recommend anybody do on their own, but do in conjunction with neurointerventional radiology. So we had all of our imaging ahead of time. Before we treated him, we got that MRA to make sure, again, there was no connection directly with the arterial system, because that's when you really get into trouble in treating these. And this was done in what's called our hybrid room. So this is the patient on the operating room table. This is a radiographic C-arm that allows us to sort of get intraoperative imaging and radiation and kind of actually do the interventional mapping. And then this is sort of are the images being displayed up on the screen here behind it. I don't know where I am in the photo, but somewhere in there. This was after kind of a medial eyelid crease exposure, and we exposed the lesion. You can kind of see that purplish hue, similar to the cavernous hemangioma that I showed you guys earlier, sort of that vascular venous blood collecting and pooling there. We couldn't have him Valsalva because he was under general anesthesia, but if it had, it would have kind of stretched and distended and increased in size. Yep. So this is kind of, I think, the video I showed you earlier. Once we had it exposed, then with neurointerventional radiology, we threaded a cannula into it, and first just injected IV contrast. I'm not sure if I think they may show the video here in a second where you can actually see that there's no connection directly with the arterial system. So withdrawing to make sure we're in the lesion, then injecting slowly with just purely IV contrast at first. And I think this video will switch to the screen to show that contrast sort of extravasating through the lesion, but not, again, communicating with any high flow arterial channel. So this is kind of our lesion right here with this network, but not really extravasating, any further beyond that. So we knew we were kind of within a safe spot within the lesion, after which we injected Trufil, which is the brand name for N-butyl cyanoacrylate. Cyanoacrylate is just like super glue. This is just a medical grade super glue, basically, that's all it is. And we actually mix it sort of in a 3-to-1 ratio with the contrast material so that we can map it as we're injecting the glue. This, as you can see, this almost looks like a still photo, but it's actually a video. It just shows how slowly we're injecting that contrast and glue material into the lesion. And again, sort of mapping it as we inject it to make sure that it's collecting here, not extravasating anywhere else, because you can imagine the consequences of injecting super glue into someone's arterial system. This just shows that Trufil polymerizes on contact with ionic substances. So as soon as it comes in contact with blood, it sort of polymerizes and solidifies. And this is just with saline and a syringe, and you can see how it kind of turns very quickly from a liquid into a solid. Once we've turned this vascular lesion essentially into something solid, we can then conservatively excise it. So this probably represents the vast majority of the lesion, but we didn't go after sort of the very distal edges, just in the attempt of trying to be conservative and not causing him any additional problems, and then just closed it up immediately. This is some of our pathologic images. This is just sort of a low magnification, just showing lots of abnormal blood vessels, some fibrovascular channels. These are sort of actually the lumens, of the vascular channel there with some blood in it. There was a little bit of nerve tissue with it as well, just a slightly higher 10x magnification of the same thing. We don't really see any lymphatic components, so probably purely venous in nature. And this is just a very, very high 20x magnification, just sort of showing the endothelial hyperplasia and the endothelial cells around these lumens. And then this is a CD31 stain, which shows sort of targets the endothelial cells, and you can really see sort of that endothelial proliferation around the edges of this vascular lesion. So he did well. Post-op week 1, this is him doing a Valsalva maneuver. Still a little bit of edema there, but not truly an expansile lesion anymore. And then this is him at post-operative month 3, and no changes at all with Valsalva. So in summary, this is just a distensible venous malformation. We did talk about these earlier. They exist on a wide spectrum of disease. They're influenced by venous pressure, and they may be associated with pulmonary disease. One of our fellows, Maria, just presented in Buenos Aires a couple weeks ago, sort of studying, are there any systemic associations with why some patients develop these? And it may be from increased, basically venous pressure. People with pulmonary disease, this patient had asthma, may be coughing frequently and increasing their venous pressure, which kind of can cause these to stretch out and distend over time. We've said multiple times now you want to avoid biopsying these, but you can consider excising them for pain, disfigurement, or some type of functional deficit. The glue is helpful for turning a liquid lesion into a solid lesion. And then you do have to counsel these patients extensively that there is a potential for recurrence after excision. So just a few of the papers I looked at in preparing for this talk, and wanted to thank Don Kikawa, who was my mentor in residency and did this case with me, and then our pathologists, Dr. Lin and Dr. Snyder.
So this is a case we actually saw on the floors last year, and it is the case of the wandering headache. So this was a gentleman who was admitted to the hospital with headache, nausea, and loss of appetite. So he had a complicated medical history. He's a 70-year-old with many medical problems, including a recent living kidney donor transplant 1 month prior to admission. He was admitted to the hospital with concerns about his kidney status, complaining of nausea, malaise, loss of appetite, and also had a left-sided headache. He also noted at the time that his left eye had been red and the vision there was becoming increasingly blurred. And not surprisingly, ophthalmology was consulted. As a side note, ophthalmology is consulted for almost anything at our hospital, but this was actually a legitimate consult. So his past medical history, like I said, it included chronic kidney disease, and he had just had a renal transplant 1 month prior. He also had high blood pressure and type 2 diabetes, cardiomyopathy, thyroid and parathyroid disease. This guy was definitely a sick guy. His ocular history included ocular myasthenia, cataracts, and he had a refractive error, unclear, but he wore glasses for everything and was unable to tell us his last eye exam. So he was on a bunch of different medications, but most importantly on prednisone, status post kidney transplant, carvedilol, mycophenolate, tamsulosin, valganciclovir, and most recently had been given Bactrim or sulfamethoxazole, trimethoprim, after his kidney transplant. So his exam that first day that we saw him was markedly asymmetric. He was 20/25 in the right eye, 2200 in the left. These were near vision, near cards. Pressure was 29 in the right, 49 millimeters mercury in the left. His EOMs were full. His visual field on bedside exam was full to confrontation, and he did not have an afferent pupillary defect. So slit lamp exam was really all about the left eye. His right eye, normal looking. He had some lid edema on the left eye. His conjunctiva was nice and white on the right eye, very injected on the left. Cornea, some mild dry on the right, and diffuse microcystic edema on the left. Anterior chamber was very shallow in the left and shallow in the right. His iris reacted in the right and was fixed and mid-dilated in the left. He had significant nuclear sclerotic cataracts in both eyes. We did not have a view to the back and were not about to dilate him, but his B-scan ultrasound was flat. So this is just a picture of his left eye the first day. Any ideas? Anyone want to give it a shot of what's going on here? Exactly. So he's having an acute angle closure attack in the left eye. So we started him on a series of, or my residents started him on a series of eye drops in the left eye. including timolol and dorzolamide and brimonidine, all of which we discussed earlier, all of which are great players as far as getting a pressure down rapidly and work well together. We gave him latanoprost, which doesn't work as rapidly, but why not? And he also got Diamox acetazolamide, 500 milligrams BID. So this started in the morning. Let's say on a Tuesday morning, my resident saw him, the resident fellow saw him, started everything going, and then they decided to swing by later on in the afternoon to see how he was doing. So the team stopped by, and he said, you know, his headache was, the left eye was fine, now the right side. Now he had a right-sided headache. So sure enough, his vision had dropped in the right eye, had improved in the left eye, so now he's 20/80 in both eyes. His pressure had gone up markedly in the right eye to 39. His left was now 8. And his slit lamp exam changes, it was now all about the right eye, which had marked lid edema in the right, much more so than the left, which was already improving. His conjunctiva was markedly injected in the right eye. He had a steamy, hazy cornea in the right with clearing edema on the left. And now he had a fixed mid-dilated pupil in the right eye, and his left eye was now reactive. So this is now what his right eye looked like. What do we think is going on here? Exactly. So this poor guy had an angle closure attack hours after his left eye. He had one in the right eye. So we started him on a series of drops now in the right eye, including the timolol, dorzolamide, brimonidine, latanoprost, and he continued on his oral Diamox. So he actually did very well, and his headache and nausea and malaise were resolved within hours of his pressures coming down. And he was actually discharged the next day once the medical team realized that it actually was not anything about his medical status. His kidney was fine. It was all about his eye. He was actually in angle closure the entire time. So he was sent home on multiple eye drops, including additional pilocarpine, and seen again as an outpatient later in the week, at which time I did a bilateral iridotomy, actually on the same day, to both eyes without complications. And then a few weeks later, he had bilateral cataract extraction, did one eye 1 week and the next eye 10 days later. And he did really well and was able to come off all drops and stayed without drops with good vision and full fields subsequently. So I thought I would take this chance to talk about what this was, medication-induced acute angle closure glaucoma. So we'll just talk a little bit about why, who gets this, why, what are some of the big players, the associated medications that can cause this, and the treatment and also prevention. So who's at risk? We talked a little bit about this before. People who are hyperopes, older people with thicker cataracts, thicker lenses. They are also on more systemic medications, which could trigger this kind of thing. Asians and Inuits tend to be more at risk, as well as in certain populations, females much more so than male. And white females have for instance, white females have a 3 times increased incidence more so than white males. And there's 2 basic mechanisms that lead to this. One is pupillary block, where the border of the iris contacts the anterior lens and basically shuts off the aqueous movement from posterior to anterior chamber. And then you get anterior bowing of the iris, and that blocks the angle. The other way this can happen is through lens iris diaphragm displacement, where you get anterior choroidal or ciliary body effusions that are pushing things forward, shifting the lens iris diaphragm forward and blocking the angle that way. So this is a very busy slide, but I just wanted to point out, so there's a ton of medications that can lead to this, some via mechanism pupillary block, some via mechanism of the lens iris diaphragm displacement. He was just put on this medication, and I think that's really what did it. So by the way, acetazolamide is actually on this list, which I find interesting. We did not give him a glaucoma attack, but I have never seen anybody with a glaucoma attack due to Diamox, but it is one of those things that could trigger it. But he was on Bactrim, which is sulfamethoxazole. But there's a ton of medications that you can see, including many that elderly patients are on. Warfarin, over-the-counter cold medications, topiramate. So the top 3 offenders, this was actually a study that was done, a Korean study that was done, and they were looking at basically the odds ratio of certain medications causing, this actually came out in JAMA in September 2022. And the 3 main medications that can cause this are sumatriptan, which is anti-migraine, topiramate, which is anti-seizure, though also used as an anti-migraine, and duloxetine, which is antidepressant. And the odds ratio by far with sumatriptan much greater than topiramate, much, much greater than duloxetine. So how do we treat this? We treat this like initially we treat it like any other acute glaucoma attack. Eye drops definitely are our mainstay, at least to get the pressure down. Low dose pilocarpine works well. Higher dose pilocarpine does not, can actually worsen the situation. Oral Diamox, acetazolamide. Oral osmotics with caution. You can give somebody mannitol, but you do have to be careful, especially in an elderly patient. You can drop their blood pressure very quickly. Topical steroid to help cool the eye and clear the cornea. IV steroids, if all this is happening from a choroidal or ciliary-choroidal effusion. Iridotomy with an asterisk, because we're going to talk about that in a minute. We alluded to, do we do iridotomies for people preventively? We'll talk about it. And then cataract extraction, yeah, that's the end of the game can happen there with a cataract extraction. How do we prevent this? Identifying at-risk patients, definitely the number one way to prevent this. So 10% of acute angle closure is actually found to be bilateral. We talked earlier about if somebody has an angle closure attack in one eye, what do you do with the other eye? You're going to have a discussion with them about, do we want to try to prevent this in the other eye too? Because once somebody's had this one time, they do not want to have it another time. Of course, everybody, I'm sure many patients or many doctors feel this question constantly about the use of decongestants. They can precipitate a glaucoma attack. So if you've identified somebody as having borderline narrow angles and you elect to watch, they should be people who are counseled against using things like decongestants. And then the question of the prophylactic laser iridotomy. So whether or not to do a laser, really. I have colleagues who, we debate this often. There was an interesting trial called the ZAP trial, which is the Zhongshan Angle Closure Prevention Trial, which is published in May of 2022. And they studied patients between the ages of 50 to 70-year-olds in Guangzhou, China. And basically what they did was they used one eye as the control eye. They did an iridotomy in one eye, and they did the other eye unlasered as a control. And they're looking at outcome rates of acute angle closure attacks after mydriasis. And what they saw was that, yes, lasered eyes had a less chance of having angle closure attack, but interestingly, not zero. But even with the unlasered eyes and people who were considered at risk, they did not really have a very high rate of angle closure. And this was when they were being essentially challenged with mydriasis. So the limitation here really is that it was a single ethnic population. So the significance is probably, most people with narrow angles, even if you identify them as having narrow angles, they're probably not going to have an angle closure attack. So a lot of people feel like you can watch this. I think we talked about this before. I tend to be a bigger fan of doing an iridotomy than not, but it's probably okay to watch people unless they need frequent dilation, like people with diabetes who need periodic dilation to look at their retinas, people with macular degeneration who may need frequent dilation. But otherwise, it might be okay to just watch people without doing an iridotomy, with the caveat that you're also sort of advising them to come back periodically to make sure they're still doing okay and haven't developed any subacute angle closure attacks. And those are my references.
So 2 awesome talks, 2 awesome presentations, and I just wanted to go over a few pearls that were actually shared with me when I was a resident by one of the great teachers of mine and an amazing lecturer. But if you think about your opportunity to present, it's really a chance to share knowledge and share that knowledge with your colleagues so that you can have a two-way communication and further develop understanding. I mean, if Rodin hadn't shared his sculptures, we wouldn't be able to talk about these types of things. So this is John Trobe, and I would put John Trobe and one other person as the 2 best lecturers that I've ever seen, and I have a picture of the other one later in the talk. John Trobe's a neuro-ophthalmologist at Michigan, just unbelievable. And when we were residents, he would get us in a group, and he would give us a talk about how to give a talk. And these were the points that he made us, and so I just want to share them with you. Know the audience that you're speaking to. So if I go to Gerardo and all of his retina colleagues, and I try to give a talk about how to fit contact lenses, I'm going to see 25 people like this, just snoozing away. Just, and that's what, you as an audience, you come from all different areas. And so for us, the challenge is to make sure that even if you're not doing oculoplastics, it still might apply to you, even as a retina specialist. So that's the goal of knowing your audience, because then they'll be interested if you know what they're interested in. Tell them what you're gonna tell them. Like right up front is fine. I mean, not with a case presentation. Those are fun to be mysterious, but if you're giving a talk about something and you wanna make a few specific points, let them know ahead of time, look, this is what we're gonna really be focused on, and then kind of focus on it and then tell them again at the end. Understanding your topic is crucial. Usually when you present, you should expect you know more about that topic than most of the people in the room. You don't have to, but you have the benefit of knowing what you're going to talk about. So do your research, read up on that topic. So if a question comes up, you might be able to answer it, but understand you might not know all the answers, and it's fine to say, I don't know. Let me look it up. Let me get back to you. This is where John Trobe was amazing, is he would always make it into a story. Like you just were so captivated by the story that you forgot that you were actually like learning about, IIH or some ophthalmic condition. And then at the end, tell them what you told them again. So reinforce those key points. The other few things I would say is just practice initially. Go over your talk a few times, especially for timing. It's easy to think like, oh, I'm going to be able to do this talk in 5 minutes, and then you go try it, and it takes you 12 minutes to get through it. So practice it a bit on your own. Try to make it communicative. For those case presentations, it's a great opportunity to say, like, what do you think this might, like Kyle did, what do you think this might be? What test should we get next? It makes it more fun. And then sometimes the more comfortable you get, the better less is more. Meaning less stuff on your slides if you can avoid it, less words, just a picture. If you have a lot, there are a lot of studies that show if you have a lot of things on your slide, people in the audience are more likely to just look at the slide and not really connect with you as the presenter. So if you just have a picture and you can talk about it and you don't need to use the slides as a crutch so much, which is fine. When you're starting, it's fine if you need to kind of read parts of your slides, but once you get a little more comfortable, try to have less on there. And also, really, people can only come away from a talk with like a few things. That's the truth of it. The rest, you can go back and look in your notes if you really want to know. So make sure you distill to the most important components. Never go over your allotted time. And I say this, actually, I think it's really important. As an audience, have you been in a talk where you're like, when's it gonna, I don't understand, is it gonna end? When's it gonna end? They're over their time, I don't see a conclusion slide. It's kind of stressful to be in that situation as an audience member. So I would counsel you this, and then I'm gonna show you a picture of my top 2 lecturers of all time. Mark Dinkin, who you guys will see tomorrow. He's getting in tomorrow, and many of you know him. And who's seen Mark lecture? He's awesome, right? I mean, he's amazing. The reason I put this picture here is because my last point is find your own style. Mark likes to drink 2 beers at a time. Good for him. But whenever I give this talk and he's in the audience, he comes up and he instantly says, I disagree with most things that Gary just said because I always go over my allotted time. And he still counts as one of the best lecturers of all time. So find your own style and run with it. And I think that's really important. So those are the key points. We talked about these, right?